wanted to start by showing you a picture. This was done during the very heart of COVID. Seems like a million years ago, but it was only in 2020, 5 years ago. And this is our little ragtag, scrappy group. Didn't know what we were doing with Governor Edwards as he was signing our first bill into law. Our first bill. We had no idea at that time what would come from that first bill. At that time, we had a little scientific advisory board. It consisted of just a few handful of folks, very dedicated, but folks who believed in our mission, Let's fast forward just 5 years, and now our scientific advisory board has 40 physicians who represent every specialty in cancer and nearly every major hospital system and hospital in the state of Louisiana. So I'd like to ask any of the members of our scientific advisory board here in the room today to stand up and be recognized. The work that these physicians put in to making the lives of cancer patients in the state of Louisiana better cannot be overestimated. They do just a tremendous job. And then we have our board of trustees. The talent, the accomplishment in this small group is unsurpassed. This is the hardest working board of any nonprofit in Louisiana, no doubt. And speaking of hardest working, Chad Landry, where'd he go? Where's Chad? Oh, there he is, there's Chad. You know, one of my colleagues told me, Chad and I went on the news last week, live news, and it was just a short segment, but one of my colleagues told me afterwards, he said, I didn't have the TV on, but I knew exactly those 2 minutes when you guys went live. And I said, yeah, why is that? He said, I didn't get a single email from Chad. I was really worried something might be wrong, but then I realized y'all were just live on TV for those 2 minutes. I said, yeah, so that's right. But Chad is the heart, the soul of our organization, and we wouldn't have a CAGLA without Chad. And, I often tell people that conferences of this size are inevitably, ubiquitously put on by companies who plan conferences. And they have dozens, if not hundreds of people who do this full time. Chad does this essentially as a one-man show and as his side gig, not his day job. So, our hats off to you, Chad, and to thank you for everything you do for our organization. Now, CAGLA really has a twofold mission. I think you guys know it, advocacy. We started with that one law in 2020, and we've since passed 14 laws. We have a 100% success rate in passing Louisiana legislation. There are not too many advocacy groups in the country. There are not too many advocacy groups in the country that can claim anything similar to that. Of course, our other mission is education, and here you are. Last year we organized one of the largest conferences in oncology conferences in the Gulf South. But this year, we've topped ourselves. And we now have 900 registrants for this conference, including nearly 700 healthcare professionals. I remember our first year, a criticism was, there are just not enough doctors there. I don't think we'll get that criticism this year. If anybody submits that criticism, you need to come see me and we'll give you an ophthalmology referral, because we've got a room full of healthcare professionals here. So what can you expect? What can these 900 people expect out of this conference? Chad alluded to it a little bit. We have 14 CME blocks with 90 speakers from around the country. The innovation track, this was Chad's baby. The innovation track brings together small biotech firms who have new, innovative projects, and it brings together potential investors to meet the CEOs from these companies who are flying in from all over the country, even the world, to present at our conference. This is truly unique. As Chad says, J.P. Morgan has a big conference of this type. There are other conferences of this type out there, but nobody has combined an investment conference with a medical conference, so that the doctors can walk over and see exactly what the new innovations which are coming are. In fact, last year when we piloted this, we actually had doctors who ended up on the boards and the scientific advisory groups for these companies because of the relationships they made here. We had docs who then were able to do research, bring in trials to Louisiana that would never have happened before because of the relationships they made during the innovation track. This year, we're offering something new, the advocacy track. Dr. Finn and Dr. Sheen are leading this. And we are bringing in advocates like ASCO, the Leukemia Lymphoma Society, the American Cancer Society, and others who will be presenting at this full-day track along with legislators. We're bringing in the legislators so everybody can kind of learn from each other. We have over 100 scientific abstracts and posters. 50 of them we'll be looking at today and 50 tomorrow. We have nearly 90 sponsors. Many of you in the room today have a table set up and so on and so forth, and we have 20 platinum sponsored dinners. And we instituted this year for the first time the National Advocacy Awards that we gave yesterday to Karen Merritt of the DPYD Associates, as well as, and she'll be giving her story tomorrow at the Precision Medicine Block, as well as Skeeter, who is the attorney who fought for his own cancer treatment, and in doing so helped chip away at ERISA, a very damaging federal law which ties the hands of many states in enforcing laws around insurance coverage. But despite the fact that we have come a long way and we've done a lot and we have this amazing growth, there is still a lot to do. There's still a lot of work to do. Cancer in Louisiana is nothing short of a national crisis. We have the third highest incidence rate of cancer in the United States. We have the fifth highest mortality rate of any state in the Union. And the area between Baton Rouge and New Orleans, if you live in that area, you have a 95% greater chance of developing cancer than the average American. And our disparities, they're the worst in the developed world. They really are. We are literally at the doorstep of ground zero as far as cancer is concerned in this country. There is no debate about this. The numbers are real. But it's all about to change. It's a new day for cancer care in Louisiana. The doctors of CAGLA, the leadership of CAGLA, have incorporated a new organization, a sister organization with a different mission. And that organization is called the Louisiana Cancer Endowment. Many states have a cancer endowment. Just next door, Texas has a cancer endowment called the CPRIT with $6 billion, a perpetual $6 billion that turns out interest each year to fund cancer research, cancer education, and is a huge economic driver for the state of Texas. It pulls in faculty from around the world because they know they can get funding through the state of Texas. Prior to the Louisiana Cancer Endowment, Louisiana had exactly 0 cents in our cancer endowment. But again, that's all about to change. So the Louisiana Cancer Endowment will fuel life-saving breakthroughs, pilot programs. We're going to start out small. We're never going to get to $6 billion. I'm going to tell you that right now. We'll never get to $6 billion. But as one of our legislative friends told me, he said, I think this is a great idea, and I think in 10 years, you can expect to have somewhere between what you have now and $6 billion. Spoken like a true politician, right? Spoken like a true politician. So what does the Louisiana Cancer Endowment aim to do? We aim to provide seed funding for pilot programs that healthcare professionals want to do. There's a million ideas that come out every year from people all around the state. Oh, I wish we could do this. I wish we had money for this. We want to seed some of those pilot programs. We want to give grants for investigator-initiated research and for bench research. and travel and training awards for our fellows and our trainees as a way to attract greater faculty and greater trainees to our area. And of course, we want to support cancer education throughout the state. LCE is a brand new organization, but we've already been met with success. We've had major commitments from CAGLA, from the Rich Maudie Cancer Fund, from the Breast Cancer Recovery Fund run by Kim Groh, the Karen Stahl Research and Breast Institute, and we've had a number of gifts, smaller gifts from patients and their families. But we are calling on all of our pharma friends. We're asking each and every one of you to talk to your upper management. Some of them we already started talking to, but we want to meet with every one of your CEOs. Chad and I want to meet with them. And we want to tell them about our vision and what we're doing here in Louisiana. And we want to ask you to contribute in some way. Each pharma company will probably have a different contribution. Maybe it's time and effort on the board. Maybe it is a financial contribution. Maybe it is sponsoring an event. But we're going to be talking to each and every one of you. So I want you to start thinking, how can we contribute to this? This is not about a doctor. It's not about a hospital. This is about the state of Louisiana. This is a statewide initiative. And I want you to start thinking about that. That said, I want to thank you. I want to thank each and every one of you, because we couldn't do what we do every day. We couldn't be a successful organization, and we couldn't drive the needle a little bit improvement for cancer patients every single year without each and every one of you. So I want to give you all a big round of applause for the work you do every day. That said, I'd also like to thank our title sponsor, Guardant Health. Guardant Health has been the title sponsor of our conference now for 4 years, and I distinctly remember when I first heard that Guardant was going to be our title sponsor. I was in Minnesota, the tiny little town of Baudette, Minnesota, all the way up on the Canadian border where my mother-in-law is from. And I was at a bakery picking up a cake from my in-laws' 50th wedding anniversary that they were going to celebrate in Baudette at the same church where they got married 50 years before. And my phone rang, and Chad told me that Guardant was going to be our title sponsor. And they have continued to support us each and every year. And not only have they supported us financially, but each year they send one of their top executives to come and sit with us and talk and really kind of go over the landscape of precision oncology and precision testing in the nation this year. I am so happy to say that this year we have joining us Dr. Matthew James Ellis. We actually have a Dr. Ellis on our scientific advisory board, and now joining us at the table next to him is another Dr. James Ellis, who is the Senior Vice President of Clinical Development and Precision Oncology at Guardant Health. He is a globally known scientist. He is an oncologist, a physician, and a cancer survivor himself. He was the co-leader of the Cancer Genome Atlas Breast Project, which is an enormous project involving many, many institutions. His work led to the development of Prosigna, which is a diagnostic platform which is approved in 20 different countries. He was the principal investigator of the Clinical Proteomic Tumor Analysis Consortium, and he developed the WIM xenograft model, which is widely used in cancer research labs around the world. He's held faculty positions at Georgetown, at Duke, at WashU and Baylor. And he was previously Senior Vice President of AstraZeneca, where he led early drug development, prior to joining Guardant. So with that said, it is my profound honor to welcome Dr. Ellis to the stage.
It's been a big year for Guardant. It's been a really big year for Guardant. When we were here last year, we had a great talk, a great fireside chat, but a lot has happened since then. And we now have Guardant Shield. And for those of you who are not familiar with Guardant Shield, the easiest way to describe it is a colonoscopy in a blood test. Right? So it's a screening test for normal, healthy patients for colon and rectal cancer, which instead of having to do a colonoscopy, just take a simple blood test. So can you tell us a little bit about the test and where it sits and how it's being used and what the company's doing with it?
Well, colon cancer is a huge problem. I think the number of people dying in the United States is around 55,000 a year. But there's a simple solution. It's screening. If you are diagnosed with stage 1 colorectal cancer, has about a 90% cure rate from a simple surgery. So there's 50 million people in the United States who would be eligible for colorectal screening, and they don't do it. Why don't they do it? Well, it's logistics, isn't it? I mean, a colonoscopy is quite a tricky thing to get organized. I get them regularly. You have to wait maybe 4 or 5 months before you can go in, and you have to have the bowel prep and all the rest of it. There's stool testing, which is very effective. But it's still a multi-step process. You get the box, you have to fill out the instructions and send it back. Really successful screening programs are one-stop shops. So you can have a phlebotomy drive, for example, in an underserved community, like the one that Dak Prescott's been participating and organizing with his charity, which is called Faith Fight Finish. Very cool, thank you, Dak. So you can go into a community and do a phlebotomy drive, and the screening's done. Really important, say in the African American community that had a higher level of colorectal cancer and they're the least screened. So this is a solution. It's not being sold as the solution, but I think blood-based cancer detection is here to stay, and as you can imagine, it's moving beyond colon cancer.
Thank you. And that brings up a follow-up question. So as you mentioned, it's moving beyond colorectal cancer. So there are competitors who are developing blood tests to treat or to screen for multiple cancers in one test. Now, Guardant focused strictly on colorectal cancer. Can you explain a little bit about why a screening test for one cancer versus multiple, and are there plans to broaden out the coverage of Shield?
Well, when you're introducing a new technology, you have to, if you like, have a positive control. So in this case was colon cancer screening, because one, it's a routine thing to do. So you weren't introducing a brand new, screening test in a setting where screening wasn't done regularly. It's well recognized screening is valuable, but you got to make sure your technology works in that control setting. So I think that's why colon cancer was chosen. But if you think about it for just 5 microseconds, you realize in the population that's being screened and in the clinical trials, they're getting other cancers. So in the background, obviously, these trials will begin to yield information on the ability to detect other cancers. We know that the technology will detect other cancers because we've been chosen by the National Cancer Institute in the I think it's called the Vanguard trial. This is the multi-cancer detection program at the National Cancer Institute. So they obviously provided lots of blinded samples from people with cancer, and we were one of 2 tests chosen for multi-cancer detection clinical trial. So we know it can do it, but of course, going from there, the promise to practice requires the generation of a lot of data, which will come out, some of which will come out this year, actually. So maybe mid-year, I can do a better answer to that question.
As far as screening tests go, you can have the best screening tests in the world, and I think our group knows this more than any other. You have the best test in the world. If our patients can't access it, it's worthless. It's worthless. So what's Guardant doing to make the test accessible? How are payers aligning to pick up cost and help with cost? And how are we thinking about sort of some of, as you mentioned, some of the most vulnerable who may not have access to this through payers?
Great question. So lots of rules and regulations around approving anything in medicine. So where we are now is we're FDA approved and we are Medicare approved. So that's a great start. Because Medicare, you have to be 65 or so or more. And so there's a big segment of the population, 45 and 65, that need private insurance. So in that setting, there's a US law around the Cancer Prevention Task Force, which if you become adopted by the Cancer Prevention Task Force, it's mandatory that private insurance fund it. But that only sits every 5 years, which doesn't seem to be often enough in a rapidly moving area like cancer detection by blood testing. So, but once we get through that, and I think they sit in 2026, then it'll be available to everyone with private insurance. And also the American Cancer Society adoption would be an important milestone as well. So, you know, if you're between 45 and 65, you can call your insurance and see if they'll reimbursement. I think increasingly there'll be ad hoc approvals before the US Cancer Prevention Task Force approval. But it's a long process, and really, in my view, way too long for something as transformative and helpful as this.
So the U.S. Preventive Services Task Force meets only once every 5 years. Wow. It's got to be a pretty great job, right?
You're a clever politician, medical politician. Maybe that's something we can push back on.
Yes.
Doesn't make sense.
Yes, yes. Absolutely, absolutely. One meeting every 5 years. Amazing, amazing. You mentioned Dax Prescott, and you know he plays for a team that is not our favorite team necessarily in the city, but he's a terrific guy. And my precision medicine program has worked with Dax to screen the Cowboys and their administrative team. In fact, and it's been on national television. It's not a HIPAA violation or anything for me telling you this. We actually found a cancer in one of their vice presidents, and he underwent treatment for it due to blood-based cancer screening. He had no clue that he had cancer. He was just doing his job every day at the Cowboys facility, and then we discovered that he had cancer. But you alluded to the fact that Dax has invested in cancer screening. And one of the big projects he's done is actually a project with the LSU Feisweiler Cancer Center. Dr. Mansour is here from the Cancer Center at Shreveport. And he has a bus, I understand, that goes around and gives free Guardant Shield tests to underserved patients around the state of Louisiana. And Dax is from Louisiana. He wants to invest in Louisiana. His mother died of cancer. And I think this is a phenomenal thing that he's doing for the patients of North Louisiana. But can you tell us a little bit about that program and why Guardant feels it's so important to partner with folks like Dax and to come out to underserved areas of Louisiana and find cancer?
Well, when you're choosing companies to work for, it's very important to understand the culture of the company before you join. And so that sort of advocacy, do the right thing for patients, it's not just a slogan at Guardant Health, it's a real thing. And as I've worked there, I've been, that conclusion about the company is only solidified in my mind. So, as exemplified by our support for your organization. And as you mentioned, I'm a cancer survivor myself, so I'm both an advocate, and an executive of the company, pushing that and keeping them to that promise every day.
We appreciate that very much. Thank you. Thank you for the work you do in that area. So Guardant pioneered the liquid biopsy, essentially invented it, if you will. And now you're the first company to have an FDA-approved blood-based screening test for cancer. Innovation after innovation. What's the next big thing? What are you working on? What can you tell us? And I don't think not all of us have signed NDAs here, but what can you tell us?
Well, I'm so glad you asked that question because that's my favorite subject. What we're doing now in the cancer diagnosis field is adding something called epigenomics to genomics. So the cancer screening test we're talking about here, Shield, is actually an epigenetic test. It's not a genetic test. What does that mean? Well, obviously there's 3 billion base pairs in your genome, and each tissue type in your body masks some of those 3 billion base pairs with a chemical modification called methylation. And so when there is a DNA methylated, it closes them off, and those cassettes of genes cannot be expressed. And that's why, your cardiac cells stay cardiac and your gut cells stay stay gut cells, and your pancreas cells stay pancreas cells. It's due to DNA methylation. Well, that methylation can be detected in the blood. And it's detected in the blood system using a methylated DNA capture system. So what that does is create a very, very sensitive measure of methylated DNA in the circulation that reflects all these methylated changes in cancers as well as normal tissues. And so, for example, you can now use that in a test that's about to be launched in the setting of, let's say, a lung mass. Now, we already know that you can take a tube of blood from a patient with a lung mass, and if it's got a EGFR mutation, it's lung cancer. You've got the genetic calling card of not just lung cancer, but a treatable lung cancer. So in the UK now, and increasingly even in the US, in those settings, people just start an EGFR inhibitor straight away. They've got enough of a diagnosis to start a treatment. But what if there's not an EGFR mutation? They still need treatment. So right now, they go through, obviously, a biopsy. Biopsy is not straightforward to diagnose lung cancer. The procedure, success rates at best are 80%. So 20% of patients will go through a bronchoscopy and it won't actually give you the answer you need. So they need a second procedure. So what we've developed is a blood test that will tell you not which type of lung cancer it is now, because that's an epigenetic phenomenon, right? Whether it's a small cell, whether it's a squamous, whether it's an adenocarcinoma. And in certain patient situations, particularly when there's trouble making a diagnosis, that may be enough for you to start a round of chemotherapy and try and get that patient better. I'm not saying it's a substitute for a biopsy. A biopsy may occur later. It's just in tricky sort of medical care situations, you need to get to a moment where you're comfortable as the oncologist to start a treatment. So I think that's just one example where I think this infinity test we've developed could help medical care. Another thing that we're developing is a blood test for whether the tumor is still estrogen receptor positive. So in metastatic breast cancer, something I've worked on for many years, one of the causes of resistance is the cells just lose estrogen receptor. But those patients can still carry on getting estrogen receptor targeting combinations, which of course futile because the tumor is never going to respond anymore. So it could be a decision-making tool for certain types of situations in advanced breast cancer where you have to make a decision to end their endocrine therapy phase and go on to something else because they're not going to respond anymore. So these are all tools, and I think that concept of blood testing and monitoring patients over time could even get to a stage where we stop doing CT scans anymore. The methylated DNA is such a good way to monitor the disease. Why are you bothering with the radiology?
Wow. You guys are going to put a lot of doctors out of business. Screening colonoscopies, radiologists. No doubt. No doubt. That's amazing. So the idea of treating a patient prior to a biopsy is pretty paradigm shifting.
No, we get a biopsy.
Yeah, eventually.
You get a biopsy. You get a biopsy. It's called a liquid biopsy.
Yeah.
Because the cancer cell is liberating its signal into the blood. Wow. It is a biopsy. You are testing the material from the cancer.
Wow.
It's just in a more convenient form, a blood test.
I love it. I love that. So, thinking about all of these tools and how we put them together, these almost science fiction tools, but we know that things that sound like science fiction today, by next year when we come and talk with you guys, will be approved. These will be approved, right? Thinking about all these new tools, what do you think the world of cancer care will look like in 5 years, 10 years down the road?
Well, what about the field of human disease in general?
Yeah.
Because what you're measuring in the peripheral blood when you're developing a cancer diagnostic is methylated DNA liberation by a diseased tissue, cancer. But tissues that are damaged by other disease processes, inflammation, for example, also liberating their DNA into the peripheral blood. So I think also we'll be using these technologies to diagnose inflammatory conditions, neurodegenerative disorders, etc. So maybe when you go to your internist in 5 to 10 years' time, you'll have a blood test and it'll say, no unusual signals from damaged organs anywhere in your body. You're good. Or it may say, there is a signal, it's cancer. Or it may say, there is a signal, I don't know what's wrong exactly, but I suggest you have a follow-up CT scan or something, because there's some disease process going on that needs further investigation. Probably better than a physical exam, right?
Yes, indeed. Yes, indeed. I think radiology has taken over a lot of the things we do in physical exam, and now blood-based molecular testing will take over radiology in many ways. Probably not diagnose a broken bone, but in many ways in the coming years ahead. So, I have a few more questions, but before that, does anyone in the audience have questions for Dr. Ellis? Does anybody want to ask any questions? Hi. Don't make me call on you guys in the back. It's okay. It's okay.
My friend.
Oh, yes, Dr. Ellis. He said, say hi to mom when you get home. Hey, what is your validation process?
Great question, right? Validation comes in many forms. We have, at this point, over 200 different clinical trials, just with investigators around the world working on validation of various hypotheses for blood-based therapeutic diagnostics and intervention. We obviously have very high levels of validation in the setting of our companion diagnostics program, working with the pharmaceutical industry. I'm very keen, actually, and this is to all the physicians out there, please participate as we develop these programs, on decision impact studies. So, for example, in the setting of things like a suspicious lung mass, providing the liquid information first, and then see, whether that's enough to proceed, or whether that patient should go to a bronchoscopy. And then we can also now have a tissue product, so you can get the genetics and epigenetics from the tissue, because that staring down the microscope thing that goes on to define different types of histologies is in itself can be problematic with mixed histologies and everything. So I'm, as an oncologist for so many years, I'm interested in the sort of evidence at the individual patient level, if that makes sense, and how we can make better decisions and build decision trees that include all this new information, but also in the context of everything we're also doing routinely to try and get to an efficient answer for every patient. So lots of different kinds of validation going on. Obviously in screening, validation involves tracking. One of the Vanguard studies did 24,000 individuals for the development of cancer over time, and see what your statistics are to see whether that leads to an approval.
Yes.
Does Guardant test have to be FDA approved before you go commercial? Yes. So there are various forms of, in general, the tests come in various forms, though. For clinical trials, we have research use only clinical trials. So they're at a diagnostic standard, but they're being assessed. And then there's something called a laboratory developed test, where there can be a limited approval, for example, with Medicare. But for anything that's for sort of widespread use, you have to go through FDA approval, which is a long multi-step process, as you can imagine. But fortunately, the rules allow for some flexibility along that journey, so that you can gain the evidence you need under tightly regulated circumstances. So the question is about education, obviously educating the patients, and then educating physicians. I'm a great believer in educating patients, obviously. We have an army of people who do that education job. A lot of that time is spent with educating physicians, because there's new information in those reports which may be unfamiliar. And we do support molecular tumor boards, precision medicine programs. But you're right. I mean, I think both for screening and the Guardant Shield process, patients need to advocate for it as well, advocate for themselves, but also cancer patients need to ask for deeper diagnostics, more efficient diagnostics to improve their outcomes. And, the interesting thing actually is the harder you look, the more you find. So I just, love moving beyond recipe book oncology, as I call it, to, mechanism-based therapies, because the outcomes are so much better. And there's still a great chunk of patients called non-small cell lung cancer without a genomic driver. That's a very long sentence that says, I don't know what's wrong with you, right? I used to irritate professors when I was growing up as a doctor in England. I'd say things like, well, the patient has breast cancer syndrome, sir. They say, well, what's breast cancer syndrome? I said, syndrome is a collection of signs and symptoms of an illness that's present but you don't understand. So in 1980, when I'm a medical student, that was true, but they couldn't tell me why this 35-year-old woman, mother of 3, was dying of breast cancer metastatic to her brain. Why did she have breast cancer? Why did it shed to her brain? Why didn't the radiation work, sir? So when I say it's breast cancer syndrome, I think that's an accurate description. So silence in the room. What do you think? What do you think the tweed-jacketed, bow-tied Cambridge professor said to me? Please become an oncologist.
I love that. I love that. Yes.
Doesn't do adenomas very well, as you probably know, right? So it is a cancer screening test, not an adenoma screening test. And you can see that as a limitation. I readily accept that. But the best test, or the best screening test, is the one that people actually take. And all tests have their pros and cons and their positive predictive values. What I would say is it's about, I think, 83%, something like that. So it's not perfect, but perfection is the enemy of good, right? And it's in the range of other similar tests. There isn't a set. I guess colonoscopy is pretty close to 100%, but that's the problem. You can't offer enough colonoscopies to 50 million Americans who remain unscreened. So I accept that it's not perfect, but it's better than, but it's in the range of other tests.
All right, I think we had another question over here. Yeah.
Yes, we are working on minimal residual disease. So what's that? So in that setting, the patient's gone through their primary treatment, and then you're monitoring for relapse. So for those who don't work in the field, for example, breast cancer, there's no follow-up. Basically, you just meet your oncologist. He or she says, how you're doing, on your aromatase inhibitor or something, and that's the end of it. If the patient has no symptoms, they come back in 6-month time. So minimal residual disease is taking a blood test to see if there's evidence of early recurrence. The problem in general, although there's emerging evidence it helps, but the problem in general, it's a very long development track for MRD. And in many settings, it's not really been shown that window of time where the patients had a molecular remission before they have a clinical remission, which can be anywhere between 3 months and a year, intervening at that point saves lives. I'm in favor of using these MRD approaches or these response approaches using a blood in both advanced disease and during preoperative treatment protocols. So you're monitoring the efficacy, during that curative phase where the cancer's shrinking, so you can say not do a mastectomy or not take out someone's rectum because they have a low rectal cancer, right? Monitor at that stage to be sure the patient's on the right treatment. So you can do mid-course correction during the curative phase and take those otherwise resistant patients and find treatments that will drive that final remission. MRD may be too late for certain aggressive cancers out. Get hold of the resistance problem much earlier is my way of thinking. So that's what I'm trying to get Guardant interested in doing with I think some success. And it's not a new idea. There are other companies that think in similar ways.
Very good.
Does that answer the question?
For anyone who wants to see all the statistics on this test, there's a complete publication in the New England Journal, I think it was December of 2024, and we've used the test. I want to make sure we can explain it to the patients what a positive and negative net. So if you want to see all the data, all the numbers, where it's greatest strengths and small weaknesses are, read that article. You can read another article in the Journal in 2024 on a competitive stool test. What I'm concluding is that this is the way to go because it's a one-stop shop. It's a good blood test, and we know we're going to get the test results. The other test is very good, very, very good. Also, but it's a crapshoot as to whether she gets mailed back to the company, to our patient population. And we have a difficult patient population.
All right, in the minute or two we have left, I have one final question. Oh, go ahead. Yeah.
So, there's a number of driver mutations for lung cancer, and somebody brought me a project that says that they can predict who's going to get the driver mutations. Are you aware of any work in that area?
Repeat the question.
So the scenario, thinking that you're thinking that
Genetic susceptibility to EGFR mutations, and how do you find that? And that's what the project is.
well, you're onto something in that patients with hereditary mismatch repair syndromes get certain types of tumors with certain mutational patterns. The same is true for patients with BRCA. They have so-called signature 3 HRD. Are there genes that predispose patients to having EGFR mutations? Probably yes, but I don't think they've been identified. So, this is the young woman, age 35, with a non-smoking related lung cancer with an EGFR mutation. Why did that happen? So I'm completely sympathetic to your hypothesis. I just don't think we've got there yet.
There we go.
That's a great idea, actually. That's a good idea. Of course, a lot of lung cancer is pollution-related, as your unpleasant red map showed, but not all of it. So it just shows how heterogeneous lung cancer is, lung cancer syndrome. There's lots of causes of lung cancer, not all of them pollution.
All right. I have one final question. You've had an amazing career, and you have had a global impact on oncology. What drives you? What drives you to get out of bed every day?
That's a great question. So I'm one of 5 boys. I was the middle of 5 boys, the only one who went to university. My brothers all consider me some kind of mutant. I think I do it because I just love looking after people. I'm motivated so much by what was described by our great introductory speaker. It's about enjoying relations with people. It's that trust. It's that thing that you bring to the table as a doctor. Now I'm in the research field. The thing I miss most is going to clinic and working with patients. But I've done that deal with myself because what I'm doing now has, as you say, a global impact. But still, patients call me up, ask for advice, and so I still have that ongoing. But I think it's that's just the way I'm built. I'm here to care for people.
That's wonderful. Thank you so much for your time today. We really appreciate it.